without further ado, perhaps we'll get started and we'll have some additional people trickle in with us. So this is Keela Shatskin. I'm chairing today. We're giving Ken a break. And today we're going to talk about schemas. So we have Paul from Good Health Pass also to participate and facilitate this discussion with us. I'm really excited about what we're going to dig into here today. And so we're going to let Paul start us off. Paul, do you want to introduce yourself?
Oh, sorry, dreaded mute button. Shall I share my screen and then I'll
Absolutely. I will stop and you can jump in.
Okay.
And for those of you who are not or are new, Ken did share the link to our collective notes. So if you want to participate in our note taking, please feel free. It's a Google Doc. It's a collaborative effort here. So all voices can be heard and we're happy to have you participate.
Perfect. Great. I'll probably leave it in this kind of mode because sometimes when it goes full screen, it doesn't kind of flick through properly. So hopefully that's okay for everyone. Yeah, my name's Paul Knowles. I'm one of the co-founders of the Human Colossus Foundation, which is a non-profit foundation based in Geneva in Switzerland. And we kind of sit it's totally in the decentralized space, somewhere between identity, semantics, and governance. So really my background personally is in the healthcare landscape, predominantly in pharmaceuticals. Been working in data management for 25 years for some of the biggest pharma companies in the world. And so I was asked to join the Good Health Pass collaborative to co-chair the standard data models and elements drafting group. And really, I kind of wanted to express there's a nuanced difference between what I would call a semantics expert and a decentralized semantics expert. So we had actually both in this group. So we had someone from, well, basically my other co-chair was kind of more of a legacy semantics guy, and I kind of stepped in to kind of bring semantics into the decentralized space. So for those of you that haven't come across Good Health Pass Collaborative before, the goal of that collaborative is to help reopen global travel by enabling health passes to be interoperable, secure, and bound to the traveler's identity as passports. And the important thing here is really about the traveling part. So there's kind of two ways you could go with this. You can either go down the more health-centric route, or you can go down the opening the economy route. And the Good Health Pass Collaborative was really about the opening the economy route. So let me kind of show you some of the data elements within this space. Certificates, credentials, and passes. I put there on the left that really everything that has been defined is really considered credentials. And when I say credentials, I mean transient objects rather than persistent database records. So these are credentials, not records. So the start of the data chain, if you like, starts from a transient record from the certificate. There's some brief definitions there, but I don't need to go into them now specifically, because I can go into them in a bit more detail in a minute. But the certificates, I guess, are what you've seen everybody producing so far, from the EU eHealth network to the World Health Organization with their smart vaccination certificates. The credentials are more kind of moving into the verifiable credential role, if you like, as we know them in the community. So where you have, zero knowledge proof, et cetera, and then there's the passes, and the passes are literally just a very small object that allows you to do something. So it's a status. Can you cross the border? Yes, no. And it's kind of all minimum viable capture, if you like. So yeah, so a certificate here, a set of claims about a subject by an issuer that can be verified in some manner, either manually or automatically. So it can be either a paper or a digital certificate. Rather than go into all of the attributes that are being captured at the certificate level, I've just put in a couple of certificates here as defined by the eHealth network. One's the verifiable vaccination certificates, and the other one is the COVID-19 antigen test certificates. So the only difference with the definitions for the Good Health Pass and what was delivered by the eHealth network is there's two additional attributes that have been added to all of the objects. One's and this was predominantly for the North American market. So in North America, they take a vaccination code called a CVX code. And also because the US market is quite fragmented, we're between the individual states, we're also capturing state province of vaccination. So in Canada and North America, we capture that as well, but that's not in the initial EU recommendations. So how do we get to these to these definitions? Well, it really all kind of started with the CDC vaccination specification. That was kind of our starting point. And with that capture, it's quite extensive, very legacy based, I would suggest. And really what we were gunning for was a minimum viable capture. So we kind of started with the CDC. Then obviously the next thing that came out was the smart vaccination certificates from the World Health Organization. We kind of cross-referenced those with the CDC. That kind of helped us get to a minimum viable capture. And then solely because we were kind of looking more at freeing up the economy and the kind of the travel industry, if you like, rather than more medical specific stuff. Once the eHealth network specification started coming out from the EU, that kind of became another point of cross-reference. And really at the end of the day, that was so comprehensive for what we needed it for, that was really became the basis of what we used. Obviously in the EU, you're going across 27 member states. So obviously a lot of the cross-border stuff is kind of fairly well defined in those specifications. And they've really done a terrific job with that. So that's certificates. And then the next model, the next kind of, you pass the baton onto the credentials. Credential here defined as a certificate issued in a form designed to be easily transported by the holder and easily verified by a verifier, especially using machine readable data and or cryptographic signatures. So this is very much into the VC data model. If those of you at the W3C, those of you that know that space. And here I've just kind of jotted down. I'll share this deck with everybody. So these are all kind of live links, so you can kind of go through it. It's kind of fairly well distilled for everyone. So in here we've got, let me see. So we've got the vaccination credential and all of the capture that we've got there. As you can see, we've kind of kept CVX code and state province of vaccination, which are not in the original EU specifications. Yep, it's kind of fairly self-explanatory what's in there. And then we've got a test credential. Actually, the EU did a really terrific job with the test credentials because they've got it down to the actual products that were used for testing that are basically authenticated throughout all 27 member states. They've actually got a list of those. So it's great for things like when we want to add predefined entries to, in this case, if you look for like the test or the type of test and the test name, we can do predefined entries on them because they're really well defined. So those are the test credentials. And then the last one was a recovery credential. And a recovery credential is really just kind of proof of when you were first first tested positive for COVID, and kind of they want to keep that as a separate credential. It's a little bit of a controversial credential, this one, because certainly in North America, people are saying that they don't particularly need this one, but as it was defined by the EU, we thought, well, we might as well capture it. And then the final part is these passes. And the passes are very simple, a credential to which all possible data minimization and anti-correlation have been applied. So it includes only the data a verifier requires to make a trust decision in a specific context, such as boarding a plane. Yeah, as I said, it's literally just pretty much a status. We've left date of birth in for the time being, and this was really based on a conversation that I had with one of the lead drafting people from the eHealth network, and they suggested that initially in here we had something like a passport number or something that they could kind of cross-reference with your passport, but the travel industry don't want that. They basically want these passes to be a supplementary document to your travel document, such as a passport. So we've got date of birth in there at the moment, and even that's still up in the air whether we're going to keep that or not. But for now, we're keeping it in. So all of this stuff's gone out for internal review. It's kind of got past internal review. It's now going to some of the broader stakeholders for what they're calling a roadshow, which will be governments, airline consortiums, et cetera, and then the beginning of next week, all of this goes out for public review. And I should say this stuff that we're doing here is only one of the drafting groups. So it's specifically really about the data modeling part, but there's another 8 drafting groups. So from trust registries to rules engines, et cetera. So I'm going to stop sharing there now and pass back to Keela, because I think Keela is going to chat for the next part. So Keela, it's back to you.
Yep. Thank you. Excellent. So I wanted to take a dive into some of the details of these schemas a little bit further, and hopefully we can have some conversation. One thing that stuck out to me, Paul, as you were going through that, is the concept of the COVID recovered credential. Mm-hmm. Is an interesting one, because you could consider their positive test sort of, could you accomplish the same thing by capturing the positive test result? Obviously, COVID, there's a nuance because it's based on their first identification, and they might have multiple positives. But it is an interesting thought that, do you really need a whole credential just for that when you kind of have the test as a solution that might be viable?
Exactly, yeah. And obviously everything, those 2 credentials, the test credential and the recovery credential, can basically be cryptographically linked back to the test certificate in this case. But yeah, you're making a good point. It's kind of a controversial one, to say the least.
To say the least. That's our edited one. Hold on one second. All right. So I wanted to jump into, and we're going to get into a couple more things around this, but I've worked with the team at the beginning of this sort of project inception to draft out what I know. So my background is working in health information exchange in the US. And so I have a extensive knowledge in what the standards are, but also what actually happens in the data, which I think is an area where there's a little bit of a disconnect between what standards designers think would be great, but then are faced with the reality of what's really available. And I think we need to make sure that we're designing something that accounts for both so that we can have a lot of things if they would be there and valuable, but that we can be prepared that they might not be there. So I can make this a little bigger so that everybody can see. So this is the schema with a couple minor things, a couple future things here that we had added, but it includes sort of different categories, which we found to be important. It's the patient in this case, right? Because we're talking about clinical data, a couple of identifiers, but then also a full set of demographics. It's the facility in which the data originates from. There's the provider of the data, but then there's also like where is it coming from? Who's reporting this result? And then the actual, this is in this case a lab result, and then the actual lab result section, which of course result value is the kicker. Is it positive, negative, etc. So that's sort of the interpretation of this lab result. And in the US, we have coding systems for labs, and that's called LOINC. Which can be used to, it's basically a unique identifier for that lab and how it was performed. So, you know, when you donate or give blood for lab tests, they have different colored tops on the vials. All of those impact the actual running of those tests. And so the LOINC codes not only tell you what was the test for, but how was it run. And so, for example, the various COVID tests, there are multiple LOINC codes to describe each of those uniquely and individually. And so using those, as you were mentioning, Paul, to set the parameters so that you can say, I will accept the PCR tests, but not the other tests. You can do that pretty definitively with LOINC codes. And so those are really critical, these code qualifier, which is which system is it. Mm-hmm. And I've also went ahead and put down the prevalence of this data in the data that I have access to so that we can have a more informed discussion about what's really available and how we can work with that. So I'm just going to go ahead and let's just look at the things that are generally always there. And so this is from an HIE perspective, which is a consolidated health system, there would be a unique identifier for that belly button or person, where the data came from, some demographics. And I think one thing that we need to be talking about is, of course, gender, sex, gender identity. Those that can be really tricky. And so I've specified the legal gender, which is usually what's on documents, although there are different guidance around certain documents can be updated versus others. When this test result was available, the actual status, which would be final or corrected. There can also be a preliminary status, and then diving into the details of those codes that I was mentioning and the value. And the values create some challenge as well. I can tell you in the data that I have seen on COVID testing, there are 1,700 different ways to communicate the result. Was it positive, negative, or unknown? And there's 1,700 different text values. So there's not detected, detected, test not performed. They'll give you a paragraph of explaining how they ran the test, and you're supposed to read the whole thing, and in the middle it says something about what's going on there. And so that can be really tricky. And so the advantages of using a centralized solution to get the health data is that those interpretations can be made before the credential is issued, which is really important. Sort of boiling it down to, well, what does it mean? Are they positive or not in the case of a lab credential? So I don't know if there's any questions on this one, or I might move to the vaccination draft. And I did have, well, let me go to vaccine first. So here's vaccine. And I'll make this bigger so that everybody can see it. And here's one where I think that sorry, I made a category too big. And move over. There we go. So this is one where, and I'm going to show you, I gathered a couple of schemas that are out there for us to look at and just sort of see what's going on in the landscape of people designing different schemas for this, which I think is Paul's mission to try to centralize that effort. But one of the things that many of them hold is this concept of a lot number. And this is true globally. And I can tell you that the lot number, at least in the US data, is awful. It's not reliable at the point of administration, right? It may be reliable in terms of distribution efforts and logistics for getting vaccines to healthcare facilities, but in terms of them documenting which lot number was administered to which patient is really, really bad data quality. So there's something like 20 people who have a lot number of like crazy soccer mom 18. It's like, was that the person's password? Got entered in the wrong field? Who knows what's going on there, but there's a lot of data quality issues. So this is one where you have to start to say, does the lot number really matter? If we're getting the data from trustworthy, reliable sources, can we reduce the necessity of that in terms of verifiable credentials, as long as we trust the source? And that's where trust really plays a huge role, because I started this whole vaccine thing, like when we were talking about this last year, saying lot number is huge. It's very important. We'll be able to trace it back and verify that that lot number went to that facility. And in practice, it's just never going to happen, at least not in the US. And here, so there's a few other things. Let me flip to my other spreadsheet and show you some of the other information I was gathering from other, here we go. So I just went and looked up a couple of COVID vaccine credentials that were out on Indy, and I lined them up so that you can, if you look across, right, like here's manufacturer, 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 manufacturer. So here's all the ones, and I have the mappings of which ones these are if anybody's interested specifically. I just got rid of their names to make them fit a little bit better. And you can see there are some interesting differences. So some of them are for one dose, like a single vaccine. So each shot is going to be its own credential. And some of them are for both. And so that's an interesting distinction that we are going to need to make. Do you track them each separately? Of course, we have shot series that are only one. And so then this credential, these fields would not be applicable. And then the other thing to consider, which I found very interesting, is for some of these, like this one, there's no date, unless, because data type isn't defined here, unless dose is supposed to be the date that it was administered, or is it dose 1? I don't know, because it's not defined. And so that's where these schemas are getting a little bit out of control in how many there are, because they need to be a little bit more definitive in exactly what does it mean? What is it asking for, so that across those multiple interpretations and communities, we can get to that. Ken, did you want to pipe in on this?
I did want to pipe in on this one. I think it's important to make sure that we put borders on our discussion, or boundaries on our discussion, or remove them completely. Is the vaccine credential only for COVID vaccinations, or is it intended to be applicable for a broader set of vaccinations for yellow fever or MMR, or what are the, in the cases where there are a vaccine that has multiple components to it, such as an MMR, or there are individual vaccines that address the diseases individually, how do we categorize those? Are we attempting to try to cover all of them, some of them, just COVID? That's an important framing of our discussion.
Yes, yes, agreed. And interestingly enough, and I'm not sure if anybody has an opinion, they want to chime in on that before we.
Yeah, I can jump in there. So certainly with the Good Health Pass stuff, the vaccination certificate can be for any infectious disease, but the testing and the recovery one are solely for COVID.
Does anyone else have an opinion on what we should be trying to tackle that they want to share?
I'm going to put forth the proposal that we try to address a broader set of vaccinations to make this useful in situations beyond COVID. I know that there already is, in the airline and travel side of the world, there is a great deal of focus on other diseases that might be infectious, such as yellow fever, to allow for, or typhoid or something like that, that might be useful in bringing in those types of credentials that are done primarily in a paper-based method. Bringing those into the fold would be, I think, beneficial and a kind of a looking forward, making this broadly applicable.
I agree. Bill, did you have something to add?
Yes, ma'am. Spent many, many years traveling, over 15, and I've got probably 6 or 8 yellow cards of all immunizations from multitude of different companies. If we can standardize on looking at, just 5 or 10 different immunizations. I think globally, from a business perspective, employers are looking a way to manage that, and not just employers, but employees as well. So I like the idea, and I think you're spot on. Addressing it now will save time in the future.
Absolutely. Yeah, I think that as we start to go through, we're sort of going through the exercise, and there are only a limited number of permutations of vaccine regimens. And so maybe we get to 80% of them. We can look at what is most viable in terms of use cases, right? I know in the US there are college admissions requirements. So that would be one that we could look at. There's, of course, the country and travel one that we're tackling here. There's all sorts of those. And so we can really, I think, tackle a lot of them, if not all of them, through this. And so that's where these ones where it says dose 1, dose 2 are a little more focused on COVID specifically than the larger set. Interestingly, we do have one, oops, sorry, I misaligned these guys, but we have one that does have a code. And Paul was mentioning CVX codes, which I was looking at, and I found another code set as well, which I'm not sure where it applies. I have a little more research to do on that. But there usually are some standard code identifiers for vaccinations. I could even tell you the codes for Pfizer and Moderna off the top of my head. But those are really important, again, in terms of setting parameters, because we only know so much now. It may be that certain countries will only let you in if you've had the Moderna one, or not if you had AstraZeneca. I mean, we're picking on some companies here, but we don't know what those rules are going to be over time and as we evolve. And so being able to identify in a structured and clear way will allow points of entry to control the rules on their side. Okay, the other one that I just want to point out, because I spend a tremendous amount of time on patient identity and data quality, is that you'll notice a couple of these only have, and actually I noticed this in yours, Paul, is that it's the patient name as a single string. And patient name is a really tricky one because there's so many cultural variations on name, and how many of them you have also. And so tracking this is going to be pretty tricky. I think we need to come to some global consensus on how many name fields do we need. But sometimes order can be confused and things like that. And so this is an area where we certainly need to dive into it and have a little healthy debate.
Yeah, Keela, you've kind of captured it the same as we did. We kind of split it into the different components. It's kind of interesting to do it that way also, because it's only really when you amalgamate a first name and a last name, for instance, that it really becomes PII. So if it's just if you're just using the first name or just the last name, then that kind of has some interesting things. So I'll show you in a minute, but we basically, in a schema architecture we flag all of the PII attributes right at source. So in our instance, none of the first name, last name, or middle name are flagged, but as you amalgamate them, then you flag it for sure. Yep.
Excellent. Oh, that'll be very interesting to dive into. Okay, so I think with that said, so these were vaccine schemas. I just pulled a couple of random samples to show you the variety and the deviation, and also to kind of hopefully get us thinking about, well, which of these fields matter? Which of them would be nice to have, and so we should include them in the schema if available. And also the ambiguity in the naming conventions, right? What does this mean? I don't know. And so trying to start to figure that out and come to a common nomenclature is going to be really important for us as well, especially as we try to make this a global solution. All right, so with that said, I believe I'm going to now pass the ball back, and we're going to talk a little bit about data structures beyond this. So Paul, back to you. We're flipping back and forth because I thought it would keep us a little more engaged. But are there any questions so far? Why don't we take a second and see if anybody has comments, questions, things we should add to, things we should be paying attention to.
Yes, if you don't mind, could I ask just a quick question? We represent a group of companies that are already creating using these standards to create travel passes and in fact, health interoperable health system for the entire Central Asian region. Our question is actually quite simple. If we understood correctly at the very beginning, your goal is to rejuvenate international travel. Wouldn't it be better to focus on a data structure, a set of schemas, and a product or product standards that are focused on COVID, and allow, for example, yellow fever and jaundice capabilities or whatever else there might be in terms of vaccination to be added later? Because those are not hindering international travel right now, whereas COVID is. So that's our question.
Yeah, so go ahead. Do you want to go?
Yeah, I was just going to say, so from the Good Health Pass perspective, it's really just about the use case. So it's predominantly about travel, but there's going to be other use cases that I think are more specific to health. And then, you might even go with a different set of recommendations. So if it was kind of more health related, it's probably worth having a really close look at the World Health Organization to see what their smart vaccination certificate requires, because it's a little bit different than the e-health network stuff. So yeah, it's kind of depends on the use case, I think. Yep.
Yeah, and I would add that while absolutely COVID is our current problem we're solving as a global community, the reality is that the data capture that happens around vaccinations and immunizations is not widely variable. So if we just are able to widen our lens to say, how do we build a solution that has a role in our community beyond recovering from this immediate pandemic, then it includes the yellow fever example, and the data structures, as long as we design them thoughtfully, will be transferable to that. So it's not that we need to solve that problem now, it's just that we need to be thoughtful in considering that as the future use case, is what I would say to that.
Yep. I should also say that having spoken to the eHealth Network people, they've informed us that the World Health Organization specifications and the EU specifications will align for kind of further down the road. So they're a little bit different at the moment, but they should become more aligned as well. So that
Yes.
we'll keep an eye on that. Yeah. Cool. So so I was just going to say the common data model that we use at Good Health Pass. So yeah, at the top of the call, I mentioned that we did a lot of kind of cross collaboration with, looking at specifications from W3C credentials, community groups, smart vaccine certificates, the Canadian COVID Credentials Consortium, the International Air Transport Association, et cetera, vaccination credential initiative. But really the reason to go for that we went for FHIR in the end was pretty straightforward. There were kind of a few that we were looking at. We were looking at schema.org. We were looking at CDISC. So I don't know if you guys know CDISC, but CDISC, those models are more to do with clinical research. So predominantly used in the pharmas, with the big pharmas. And then there was FHIR, and with FHIR, that was recommended by the World Health Organization, by the EU, the Vaccination Credentials Initiative, and also a lot of jurisdictions were outside of the EU were putting that as the common model to go for as well. So, for instance, I live in Switzerland, and the Swiss are now looking at a pass solution, and they're going with FHIR as well. So. So in the end, we decided that we'll stick with that. The only caveat that I would say with that is that FHIR's adoption is still relatively uneven, and there are many healthcare systems that have not or could not adopt that data model. So to address this, Good Health Pass has kind of recommended that the solution providers should provide guidelines or tools to convert non-FHIR formatted electronic health record data into FHIR formatted records as a kind of a pre-processing step. That's kind of how we got around that. But yeah, as you all know, you can't please everybody. But in the end, we really just had to put a stake in the ground, saying, okay, we're for our purposes, the common data model will be FHIR. So that's all I had on that one. I've kind of shaved off some time, so I can pass back to you, Keela.
Sure. And I was just going to go into FHIR just a little bit because I don't want to make too many assumptions about how much people know about that, since it is, generally speaking, a health standard. So I'm just going to touch on this really quickly and expand on what you were saying about FHIR as a background and whole. So I think what Paul was hinting at is that FHIR, so HL7 Health Language 7, excuse me, which is an international standards body, has a tremendous amount of buy-in in the healthcare industry. So they have several active specs that are in existence today. The oldest being V2, which is very widely implemented. It's been around for enough time and has it's very transactional. So it's a push transaction model. They have a V3 model, which is more query and response, but sort of plagued with a lot of structural issues and content issues, and is also very heavy for not communicating a lot of value. And the newest one is FHIR. And I think there's a lot of promise for FHIR being the sort of happy medium between those first two models that I've mentioned, which allows it to dictate not only the structure of those messages, but also the content and use of that field. So that's where it's really appealing. And I think, you know, where I was sitting saying, what does dose mean in this schema, FHIR would define that, and it would be known by all and used the same way by all. And so as sort of just building on what Paul was saying, there's a couple of things to know about FHIR. First of all is that it's new and therefore not widely implemented, but it's also still evolving as a standard. So the two that are important to this discussion is they're called resources, these kind of concept blocks. And the immunization resource is only at a level 3 in terms of its maturity. So it's still changing. I can tell you it changed since the last time I looked at it as I was preparing for today. But the observation, which would be where lab data goes, is normative. So that would be unlikely to change. It's much more stable in terms of communicating lab data through this standard structure. And so the other challenge that we've had, as I've had some experience with FHIR personally, is that while the structure is really great, doesn't necessarily mean the content's going to be there. So you have to be able to set the cardinality to guarantee that you're going to have what you're looking for. And it's a very, very loose model. And so unless you specify, it could also be the wild west of interpretations of specs. But it's flexible in that it also, yeah.
How have you, and then Paul, how have you dealt with the variability of the contents of the data field? What techniques have you done, and what can you recommend to others that how they deal with the variability of that data?
Absolutely, good question. So because I am a spreadsheet geek, I translated the FHIR spec, which I can also show if you have not been there. So this is the FHIR immunization resource, as I said, sort of concept blocks. And so you can see that here, and its cardinality. And the ways that you can deal with this are either to apply translation layers to sort of say, you're not quite following the rules, let me fix that for you, if they won't fix it. But you can also design what's called a profile. And so if I just jump back to my spreadsheet, the profile is where you would define something that was looser in the base spec, but is required for this use case. And so, for example, the immunization protocol applied section is not required. However, if we want to use this for credentials, we need to know what number dose was it in the series? Is it a series? Is the series complete? Those things would be really valuable and in fact critical to make this work. Paul, do you want to answer that as well?
Yeah, sure. So, we kind of do it a little bit differently in that we've got over at Trust Over IP Foundation, there's a fire focus group, and they've been working for the past 11 months on working between fire and an architecture called overlays capture architecture. Which is really a very interoperable schema structure. So it's great for when you want to do credentialing in multiple languages and that sort of stuff. But it's almost done as a two-step process. So this fire pipeline that they've developed can ingest the entire fire R4 data model. So with all of this stuff, different jurisdictions have different immunization packages or bundles, whatever they call them. Extensions is it? Thank you. And so it's really up to the user which one they want to use. But we've kind of automated that process so they can kind of select the one they want to do. With Fire, there's a lot of great quality control mechanisms that are already in place. So we don't change any of that. You can kind of do all of the quality control stuff before it gets into the pipeline. And then we kind of do it as a two-stage process. So if you want to transfer Fire around the place, that's kind of one process. But at the same time, we also transform it into OCA, which is kind of a much better solution for multilingual credentialing. So it's kind of and that's all kind of automated through the process as well. But that's kind of the way that we got around some of the flexibility with the different data capture for the different jurisdictions and stuff.
Mm-hmm. Yeah. And I think your point also about the translators is really important to touch on, because the reality is that while the healthcare industry is putting a lot of faith in Fire, and one thing which maybe we didn't make clear is why Fire is going to be also, especially, and I can speak to this for the US, the federal government of the US has made Fire a required standard for interoperability in terms of allowing data to be exchanged with apps and the patient. And so there is now a mandate that says that you need to be using Fire to do that. And so while nobody's asked for it yet, right, because it's just new regulation, it's going to lean everybody in that direction where they have to be compliant with Fire, and its plugins to support apps is much more viable than anything the healthcare industry has seen to date. So that's really important. But where I was on the translators is that because it's going to take us a while to get there, people are still using, I mentioned there were 3 standards, V2, V3, and now Fire. People are still on the V2 standard for exchanging immunization data. And so if we're going to get it into Fire, the other challenge is to say, okay, let's map this correctly and see if we can fill in the blanks where people can't get to that standard.
Mm-hmm. Yep.
All right, excellent. Any questions on Fire or what it means? It's a behemoth of a spec, so it's a little overwhelming if you haven't been there before, this standard.
Yeah, so I should say it's also a very nested model, so it is quite tricky. It is a bit daunting to work with at first, but once you get used to it, it's not as bad as it looks. So yeah, don't be put off by it.
Yes, agreed. But just beware that, as I mentioned, immunization is only at maturity level 3. So it will continue to evolve just a little bit here as we try to get that to a normative state. But I do think that it is far enough along that it would be reliable as a structure, and certainly because of the weight that it has in some of those larger federal and government projects, it really is the route to go. Okay, Paul, I think you have a couple more things you wanted to touch on, and then we'll see where we should go from here.
Yeah, sure. Yeah, I'll go back into my deck. Okay, cool. So this was that layered architecture that I mentioned, and this is really the way that we're using it is predominantly for the human readable aspect of it. So you can kind of think of OCA as a 3D schema structure, and where you traditionally have a schema with all the things in there, sort of predefined entries, human readable labels, formatting, maybe some information prose to help the data entry process. Every single human readable thing that a schema can do is split into a separate linked object, and so I can kind of so it's really, you know, it's very good for semantic harmonization between data models and data representation formats. But for the case of Good Health Pass, the thing that really got it over the line was that you know, it can easily be resolved in multiple languages. So what I can do, in my slide deck, I have actually kind of done some capture on some of the specifications, but rather than do that, let me bring up the actual specification so that you can kind of get an idea of what an OCA specification looks like. So in here, we kind of obviously have all of these capture objects, so like a vaccination credential, some description, etc. But then what you can do with OCA is where you have, so you've got all your attribute names here, type, and this blinding block. So this is what I was mentioning before. So like here, you've got birth of date. You can flag that in the capture base, some format overlays, blah blah blah. But then what you can do is because you've got these overlays, you can kind of do a different label overlay in, you know, 65 different languages, and then, you know, so here we've got, you know, English, UK English, I should say, German, French, Italian, Spanish, Polish, Finnish. You've also but then you can also do the predefined entries in different languages as well, which is really cool. So like for this one here, passport, so this is a document type. So here, document type, you can do passport, national identity card, but then you can have your predefined entries in all the different languages as well. And then the last one was the information overlay. So this is where you do like data entry hints for each of those attributes. So again, you can do that in multiple languages. And so all that means, I'll just stop sharing there and go back into the deck. Let me see, Keynote. So yeah, so all that means is what you were saying there is that, so for instance, the different labels, all you do is, you know, when you go to go for the, when you hash the entire structure, if you like, you can hash it with, you know, different entries or labels in different languages. So when you resolve it on your mobile phone, the verifiable credential, you can easily toggle between the languages. And what's good about it is the capture base remains stable throughout the whole capture. So if you did want to amalgamate the data further down the process for sending it to the World Health Organization or something like that, none of that coloration from the overlays gets in the way of the aggregation process. Because the capture bases remain stable. So this is one of the semantic harmonization pieces that we're pushing through the Good Health Pass as well. Yeah, we see this as a kind of a neat credentialing solution for multiple languages. Yeah. That's all I had on that. I've put here my details as well. So, you know, if you guys want to email me on anything, feel free, or you can contact me on LinkedIn as well. If you have any questions about any of this stuff. As I say, I'll share the deck with everybody, and where anything's underlined, it tends to be a deep link to something. So you can click through and see kind of a distilled version of what they've done over at Good Health Pass on the semantic side. Yeah.
Excellent. Thanks, Paul. So this was a lot. I think this was a lot of information that we covered today, and it may sort of be peripheral to the details of what some of you are working on. So why don't we stop and let's see if there's any questions or comments. Maybe we need to take it back a notch and go a little deeper into this, if that's if it was a little over people's head or a little around the goal. Any questions? Okay, and Paul, you said the timing on the Good Health Pass, is that some stuff is happening in the next week or so?
Yeah, so it's been happening for seven weeks so far. That was done for all of the drafting stage. So it's a pretty hefty document that we're looking at the moment. There's about 180 pages between all of the 9 drafting groups. But it's just an interoperability guide, and we're now pushing to say, okay, well, that's great. You can kind of show it to governments and stuff, but then what? So we've been pushing to try and do some light technical implementation guides to help people to use some of this stuff. The issue we're having at the moment is that Good Health Pass was not in scope in the beginning, and suddenly now all these big Fortune 500 companies, they don't have any money for technical implementation guides, which is totally beyond my wits. But so what we're trying to do now is trying to push it through Linux Foundation Public Health to try and find some funding so that the tech geeks can start doing some of the technical implementation stuff, because I'm always a firm believer that, you know, people like me who are kind of more conceptual, we can kind of lead drafting groups and stuff. It's not too bad, but once the technical guys get involved, they need to be paid. So yeah,
that's right.
So the next stage, so with Good Health Pass, yeah, gone for a road review at the moment, and then after that, starting the beginning of next week, I think all of these drafts go out for public review. And then while everything is going for public review, I'm hoping that we can start some of the technical implementation guides. And how deep we go there, we probably won't go deep in those technical implementation guides, because I think with all of this stuff, the verifiable credentials within our communities, we understand the technology very well, but outside of our communities, it'll be like, you know, it'll be like an alien language to some people. So we have to still kind of keep these technical implementation guides fairly generic so that people can kind of start to get into the mindset of what verifiable credentials are and how that whole how that sort of ecosystem can work. But, yeah.
Excellent. Okay, and we had a question about whether or not we'll share the presentation. Paul did say he will, so we'll be able to get that out to everybody. And certainly we can have follow-up discussion as needed or as wanted by the group. All right, I think with that, we're just at time. So we'll see everybody next week.
Next week's discussion, I think we're going to be going a little deeper dive on the mobile side of things to talk about how you might look at the code there and participate.
Excellent. Thanks, Ken.
Excellent.
Okay, everybody, have a wonderful day.
Thanks, Ken. Thanks, Keela. Cheers, everyone.
Bye.
Thank you for your time. Thanks.
Bye.